Good day, everyone, and welcome to the Med Safety Exchange for this day, the 31st of May, 2023. It is the last day of May for this year, and we're pleased that you are going to spend an hour with us. Thank you for joining us. We know that things are still very busy, and you're out there doing terrific work, and we really appreciate you having in the audience. My name is Mike Hamilton, and I am the Medical Director at OZEMPIC Canada. And this webinar is a production of OZEMPIC Canada and CMERPS with contributions from everybody we work with, all our partners in medication safety, and especially you, the audience. I'd like to begin with a land acknowledgement for our office in Toronto, and I encourage you to reflect upon where you work and reside. We acknowledge that we are on the lands of the Mississaugas, the Anishinaabe, the Haudenosaunee Confederacy, and the Wendat, and we also recognize the enduring presence of all First Nations, Métis, and the Inuit peoples. We are very grateful to live, work, and play on this land, and we do want to contribute to the implementation of the Truth and Reconciliation Commission's 8 health-related calls to action. The goal of the webinar is really to encourage reporting, sharing, learning of medication incidents and medication safety topics. We learn best from each other, and we really do appreciate the generosity of our presenters in sharing their expertise and experience. We hope that you can use this learning, this information presented in the webinar in your own organizations, and in turn, share your experience with others. And we really do, I think, have a terrific webinar planned today. OZEMPIC Canada recently published a CMERP safety bulletin on the newer classes of medications for diabetes treatment. And we'll continue that learning with an initiative looking at reducing the harm related to the SGLT2 inhibitors, or the Flozin type drugs, and the safe use of these medicines during acute illness. And then we'll turn a bit to look at errors involving a GLP-1 receptor agonist. Now, both of these classes have indications for diabetes therapy, but they also have indications for other conditions as well. And sometimes these are at different doses and different timings. So there's lots of opportunity, I think, for confusion when using these products and lots of opportunities for improvement. And finally, I'll come back and give an overview of the Pan-Canadian Diversion Risk Assessment Tool, which we hope will provide organizations with a good base assessment and a foundation of knowledge in addressing controlled substance diversion. And now I'll hand this over for our first presentation to our first speaker, who's a very good friend of OZEMPIC Canada.
Thanks for that introduction, Mike. Well, I'm going to get right into it. Here's a description of the medication incident in question. Patient was admitted to hospital with a home medication combo of Janumet. This was not continued in hospital. Rather, it was changed to canagliflozin and metformin. There was also an order for prednisone that increased the blood glucose levels. Not long after, the patient developed euglycemic diabetic ketoacidosis, or EDKA, and had to be transferred to our ICU for management. The DKA protocol involves an insulin infusion, which was initiated. The canagliflozin was held, discontinued, and the serious adverse drug reaction, or SADR, was lodged via our internal reporting system. The patient subsequently recovered with treatment and was able to step down from ICU level of care. The SADR to canagliflozin was documented in the health information system with reaction detail for future reference, and the drug was not restarted. Purpose of this slide is to highlight the key message that there's a greater risk of EDKA in patients with diabetes who are on the SGLT2Is. It also shows the characteristics of how EDKA presents, as well as some required blood work for diagnosis. Finally, there are several contributing factors that can trigger it, some of which you will note can be consistent with hospitalization and/or acute illness. For context or background on our operation, we're referring to a 400-bed community hospital with paper charts, verified pharmacist medication order entry, and computerized medication administration records, or CMARs, at the time of the event. Since the original incident was a few years ago, processes have changed, such as the implementation of a full electronic health record not that this was found to have contributed to the events. When it came to analysis of the incident, we followed our usual steps of convening a multidisciplinary group and conducting a quality review, which was led by a risk management consultant. This process involved reviewing a synopsis of the event, the consequences for the patient, what went well, and finally identifying opportunities for improvement. The SADR report was filed with Health Canada as per the regulations, and an external incident report was submitted to the National System for Incident Reporting, or NSIR. My role is responsible for filing both of those. You will note an asterisk regarding the NSIR report. That is because it was a second event with an SGLT2I, empagliflozin in that case, that triggered it. Hospital policy includes this step based on the severity of the medication incident. And a key linkage, in my opinion, comes in here as ISMP reviews NSIR reports regularly and reaches out to reporters for more information. The review uncovered a couple of potential contributing factors, including a lack of understanding on how SGLT2Is, such as Invokana, Jardiance, and Forxiga, for those who may be more familiar with the brand names, should be handled in an acute care setting. Specifically, that they are not appropriate for patients who are acutely ill. On a related side note, those that are familiar with the old SADMANS sick day medication list may be aware that it is now SADMANS, with this class of drugs accounting for the second S. Anticipating a question on this reference, the list can easily be found via Google search, but in brief, the letters stand for sulfonylureas, ACE inhibitors, diuretics, metformin, ARBs, NSAIDs, and now the SGLT2Is. Another possible contributing factor was the review found no formalized process in place to monitor for signs of or potential for EDKA. In detail, lack of support such as the blood work order is consistent with what we saw on the earlier slide. Remember, these were venous blood gases, ketones, and electrolytes. With respect to strategies or recommendations that came out of the review, the first was to create an alert for particular review by pharmacists whenever these drugs are ordered in hospital. This evolved into the development and approval of a medical directive, allowing pharmacists to hold orders for canagliflozin, dapagliflozin, or empagliflozin, excepting specific scenarios. These included where the patient does not have diabetes, so for example, where the drug is prescribed for a cardiac indication, where the patient is admitted to the psychiatric unit, where it would be implicit that they were medically stable, or if it was ordered by an endocrinologist or the IDMS team, which stands for Inpatient Diabetes Management Service, with the rationale that we could count on that subgroup having a particular expertise. Another recommendation was to arrange educational sessions for targeted prescriber groups on both the risks and benefits of these agents, what to watch for, and finally that key message of either holding existing therapy or not starting them in patients with acute illness. This subsequently expanded to the nurse practitioner and the nurse specialist on the IDMS team, doing informal teaching for both nurses on all units and the pharmacist group. With the latter, they were then armed to intervene on orders during the interim period before the medical directive was finalized and approved. Initially, the alert took the form of a system report listing all patients with active orders for canagliflozin, dapagliflozin, or empagliflozin, with plans to integrate into the new EHR as it came online. The medical directive was developed and approved, allowing pharmacists to discontinue or hold orders for these drugs unless the specific criteria was met. To be explicit, discontinue was in the paper world, held in the CPOE or electronic system. A pre-printed order set was created to support the directive initially in the paper-based system, and an example of it follows on the next slide. Educational lunch sessions for both the docs and the NPs were held. This is an example of the pre-printed order, key content that we had as part of the medical directive. As per our usual process, the events were shared in several forums within the institution, such as Pharmacy and Therapeutics, Medication Safety, Board Quality of Care, and Patient Safety Steering Committees. With respect to a held SGLT2I order at discharge, the MRP, or most responsible physician, is either to restart the med or provide instructions on when the patient is to resume if it is later. For SADR events, the drug is entered on the chart as an allergy with reaction details, and the patient's community pharmacy is contacted. Also, the drug is not restarted in the case of SADR events. So how has it gone? Well, we've had no negative response as far as feedback is concerned. We did modify the parameters for exceptions on the medical directive once since it was first approved. This was adding cardiology and nephrology to the approved prescriber group and went through our medical advisory committee for endorsement. With regards to success, as of the preparation of this presentation, there have been no in-hospital occurrences of this type since the work was done. Finally, in closing, I would like to note recent interest on this topic on the Medication Safety Officers Society discussion board, as someone there asked if people are seeing this type of event with these drugs, if they had successfully curtailed their use in hospital, and how. So it is definitely being discussed in a number of areas. And lastly, reporting to Health Canada is important. We see this scenario regularly as reason for admit, and the patients generally end up in ICU. This likely accounts for about 3/4 of our SADR reports externally to Health Canada. That concludes my presentation. I'd like to say thank you very much to ISMP Canada for the opportunity and to the participants for their time and attention.
Well, thank you so much for that. I mean, not only is this a really good example of good quality improvement clinically, but I think it's really nice to follow from the incident through the analysis, a real systematic approach to looking at all the contributing factors, as well as a systematic approach to making the improvement. And also, it's clear that you're actually evaluating the things that you implemented to see if they actually are effective, and to see what the clinical or the response from the clinical staff has been. So, thank you very much for sharing, and look forward to discussing more with you in the question period. So, what I'd like to do now is turn this over to another diabetic therapy and list of related medication incidents related to semaglutide.
Good morning, my name is Hernie and I am a U of T PharmD student currently working at ISMP Canada. Today I will be presenting on semaglutide-related medication incidents. Semaglutide belongs to a class of medications known as glucagon-like peptide-1 receptor agonists, or GLP-1 agonists. This class of medications mimics the GLP-1 hormone to stimulate glucose-dependent insulin release from the pancreas. Hence, there is less risk of extremely low blood sugars with this drug because insulin release only occurs when blood glucose levels are elevated. Semaglutide also delays gastric emptying, which makes you feel full longer and can reduce food cravings. Thus, it has gained popularity for significant weight loss effects as well. OZEMPIC is a semaglutide injection approved in 2018 to improve glycemic control in adult patients with type 2 diabetes. It can be used as monotherapy or an add-on anti-hyperglycemic agent. There is also off-label OZEMPIC used for weight loss as well. OZEMPIC is available as pre-filled multi-dose pens administered through a subcutaneous injection once weekly into the abdomen, thigh, or upper arm. There are 3 different pre-filled multi-dose pen formulations of OZEMPIC. Each pen has a different total amount of drug, different dose delivery, and different total volume. The 2 mg pen delivers 0.25 mg or 0.5 mg per dose. The 4 mg pen delivers 1 mg per dose, and the 8 mg pen delivers 2 mg per dose. In Canada, currently only the 2 mg and 4 mg pens are marketed for use. There are other semaglutide products approved by Health Canada as well. Rybelsus is semaglutide tablets also indicated for glycemic control in adults with type 2 diabetes. Wegovy, on the other hand, is another semaglutide injection, but it's indicated as an adjunct for weight loss. All 3 of these products are approved in Canada, but Rybelsus and OZEMPIC are the only 2 currently marketed. ISMP Canada has not yet received reports of errors related to Rybelsus, perhaps because it is a newer agent. So the focus of today's presentation will be OZEMPIC-related errors. For the rest of this presentation, I'll be referring to the semaglutide injection as OZEMPIC. This recent multi-incident analysis and publication on the newer classes of medications for diabetes treatment included many errors related to semaglutide, specifically OZEMPIC. OZEMPIC had the 2nd highest number of incidents analyzed in this multi-incident analysis. Based on this information and the recent media coverage on OZEMPIC, a focused look at this product was warranted. Upon analysis of incident reports ISMP Canada received related to OZEMPIC, the errors were categorized into the following workflow steps: prescribing, order entry, dispensing, and prescription pickup. OZEMPIC requires once-weekly dosing, but this can be easily mixed up with dosing regimens of other anti-diabetic injectables, including other GLP-1 receptor agonists. Liraglutide, for example, requires an injection once daily. In one incident report, a patient reached out to their pharmacist stating that their Ozempic prescription label said to use it once daily. Without looking at the filled prescription, the pharmacist routinely had counseled the patient to use Ozempic once weekly. The prescriber in this case inadvertently wrote once daily, but this was not caught during order entry or the dispensing stages. Some incidents described to the ISMP Canada team reported that prescribers have been writing prescriptions for Ozempic based on the number of clicks of the pen to allow for doses outside of the manufacturer's device settings, which are 0.25 milligrams, 0.5 milligrams, 1 milligram, and 2 milligrams. There are some potential concerns with this. The manufacturer monographs recommend only using predefined doses per pen, as in turning the dial on the pen until the desired dose appears in the window. When counting the number of clicks for in-between doses, there's a risk of losing count and not having a visual dose in the window to confirm that the desired dose is being administered. The only doses that appear in the dose window are those designated for the pen. In the example on the slide, that would be the 0.25 milligrams and the 0.5 milligrams. To help prevent prescribing errors with Ozempic, prescribers are encouraged to request that electronic prescribing platform providers update the system to auto-populate the dosing frequency for Ozempic to once weekly. Additionally, if prescribing outside of the parameter described in the product monograph, ensure robust patient education and clear communication to the pharmacy team through the prescription. Numerous incidents were reported concerning errors at order entry, particularly regarding the wrong day supply calculated and the wrong quantity of multi-dose pens dispensed. As previously mentioned, in Canada, Ozempic is currently available as 2 multi-dose pens, the 2 milligram and 4 milligram pen. Pharmacy teams might not be aware that multiple pen sizes are available and that each can deliver a different dose. This leads to the dispensing of incorrect quantities. In one report, a prescription for Ozempic 1 milligram had a total authorized quantity of 13 milligrams and was mistakenly filled for 13 pens. The error was caught at product check in this case. In another report, a prescription for a 0.25 milligram weekly dose was incorrectly logged into the patient's file with the 1 milligram per dose pen. This is a sample calculation for the first error previously mentioned, where 13 pens were almost dispensed. Since the prescription stated a dose of 1 milligram once weekly, the correct product would be the 4 milligram pen, which delivers 1 milligram per dose. Based on a MITE of 13 milligrams and a total amount of 4 milligrams per pen, the correct quantity of pens that should have been dispensed is 4. Ozempic use involves complex dose titrations. Patients are maintained on a starting dose of 0.25 milligrams weekly for 4 weeks, then the dose is increased to 0.5 milligrams weekly. Further dose increases are done if additional glycemic control is needed. In one case, a patient brought in a prescription for a titrating dose of semaglutide to be filled at a later date. Pharmacy staff only entered the first part of the titration regimen and omitted the second part, because they didn't know it involved multiple steps and products. Luckily, this error was caught and corrected before it reached the patient. Here is an example of a titration order for semaglutide. The patient has been directed to inject 0.25 milligrams subcutaneously once weekly for 4 weeks, then 0.5 milligrams subcutaneously once weekly. The total quantity authorized says 3 months. As you can see, there is a lot of information on this prescription that can be omitted or confusing. To figure out the quantity to dispense, a calculation must be done based on the dose, frequency, and total amount of drug per pen. But first, the correct Ozempic pen must be selected. Thank you to some of our pharmacy colleagues who were able to show how varied the display is when selecting an Ozempic drug product during order entry. As you can see, the information provided is not sufficient to distinguish between the products in the first example, but the information display gets progressively better and more detailed with each example, such as in the bottom image where the color of the boxes and dose delivery information are both included in the name. The following tips can help make order entry steps safer for Ozempic. To confirm calculations for the dose, product, and quantity to dispense, incorporate an independent double check in the dispensing process. Use the information on the packaging of the product to differentiate total milligrams versus milligrams delivered per dose when doing calculations. When designing label instructions, try to keep the end user in mind. Input each step in the titration as a separate prescription, instead of a multi-step titration on one prescription. This necessitates patient counseling with each step. If the multi-step titration is included on a single label, number each step of the titration for clarity. To address gaps in knowledge, develop educational materials to inform staff about Ozempic pack sizes, dose delivery options, and dosing titration regimens. A comparison table of this information can provide a quick reference in the pharmacy. At the dispensing stage, similar packaging of different strength products contributed significantly to medication errors as well. Since Ozempic is stored in the fridge, finer details on the label might not be as visible, and this might cause staff to easily pull out the wrong product strength and dispense it. A caregiver called into the pharmacy wondering how to administer a 0.25 milligram or 0.5 milligram dose using a 1 milligram Ozempic pen. It was at this point that the pharmacist realized the wrong product was dispensed. To help prevent such errors, encourage your staff to always use the barcode scanning function to ensure the right product is selected during filling. You can also separate different strengths of Ozempic pens in the refrigerator using a shelf divider or individual bins labeled with each strength. Lastly, many patients report getting the wrong prescription handed to them. Ozempic is stored in the refrigerator before and after a prescription is filled. Selecting the wrong patient's prescription from the refrigerator has been a commonly reported error. Refrigerator space needs to be regularly assessed and better organized to avoid such selection errors. In one incident, a patient received another patient's Ozempic, stored in the fridge under the same letter of the alphabet. The patient injected a lower dose for 2 doses before catching the mistake. Here are some tips on how to deal with refrigerator space limitations and ensure your patients get the right prescriptions. Organize filled refrigerator prescriptions alphabetically by the patient's surname. Label and position filled prescription in the fridge such that the patient's name is visible. Use the opportunity during pickup with the patient to open the bag and conduct a final check. Confirm the correct patient, medication product, dose, and instructions for use. Ozempic is increasingly used off-label and has gained popularity in the media for its weight loss effects. Saxenda is another GLP-1 agonist approved for weight loss in Canada, like Wegovy. Currently, Saxenda is the only GLP-1 agonist medication indicated for weight loss in the market, and there is an actual shortage. This shortage can increase the off-label use of Ozempic for weight loss. But based on Drug Shortages Canada, there is currently no reports of shortages for any semaglutide products, including Ozempic. Health Canada noted an increased demand for Ozempic, but has stated that the supply is meeting the current demand in Canada. To mitigate the risk of shortage, some regulators are implementing limits on the provision of the product outside its own population. We encourage all healthcare providers to review their own incidents in addition to learning from this presentation to ensure the safe and appropriate use of Ozempic and minimize workflow errors. I wanted to end with this reference guide on the Ozempic products that might be helpful in the pharmacy for both order entry and dispensing errors. It's available on the manufacturer's website. I look forward to any questions or additional strategies in the chat. Thank you.
Thanks so much, Harneet. That's a lot of information and a lot of interesting outcomes from analysis. And you mentioned sort of encouraging reporting, and that's really, I think, one of the benefits of the analysis of aggregate data. This is a great example of this. So like individual organizations, practitioners, even caregivers, they're not likely to experience the volume of incidents or these rare incidents that would make aggregate analysis possible or learning from it. So it's really the sort of collective generosity of individual reporters that were able to learn so much about this and come up with some strategies as you presented. So, like Carnita, I encourage everyone to keep reporting their medication incidents or just concerns you have about these products through your local channels or directly to OZEMPIC Canada or to Answer. So now it's really my pleasure to talk to you for the next few minutes about the Pan-Canadian Diversion Risk Assessment Tool. Really created to help your organization better understand controlled substance diversion and reduce the risk of harm to patients, caregivers, and your organization itself. So in 2020, our research team with Mark Fan and Patricia Turbovich out of Human Era and out of the U of T published an analysis on Health Canada data of a controlled substance losses from 2012 to 2017, and that represented about 5 3/4 years in that data set. And it was noted that over 140,000 reports of loss of controlled substances. This is across all sectors that reported. But interestingly, came up to 170 million oral morphine equivalents of opioid, and worth close to $9 million in wholesale costs, and certainly more in street value. And along with that analysis was separating the types of drugs or the amount lost per facility type into morphine equivalents. And as you can see, hospitals reported losses of around 10 million morphine equivalents over that time frame. And if we further broke it down to understand why facilities lost medications, things like breakage, undershipment, losses in transit, theft, we noted that hospitals, and the most common reason cited in hospitals was opioid loss was pilferage, with about 800,000 milligrams of opioids lost. And coming in at second, and maybe more concerningly, is that over 475,000 milligrams of opioids were lost for unexplained reasons. So organizations are losing opioids and controlled substances, but really have difficulty explaining how they go missing. And what this says to us is that facilities don't have systems or processes in place to understand the mechanisms and inherent vulnerabilities associated with controlled substances. And consequently, they struggle with the monitoring of opioids and the detection of diversion. And that's really not surprising. There's not a lot of literature out there on good practices. There's really a global lack of guidance about how to have robust end-to-end controlled substance processes in hospital. And it's really something that we as healthcare practitioners don't often talk about. And maybe to lend some perspective, we can go through an example case. And this is a real life case from the US with some details changed to maintain anonymity. So the manager of a mid-sized hospital pharmacy relies on Carl, who's a pharmacy technician, to be the lead narcotic technician. And Carl's been employed at the facility, forever, knows everybody, knows everything, knows where everything is. And he takes care of the daily closed loop reports and identifies and reconciles any discrepancies. And because he appears so meticulous, he's in charge of inventory management, receiving, stocking, ordering, stocking vaults, counting and restocking ADCs. And he also manages to transfer waste product to the external environmental company. And one day, unfortunately, Carl's involved in an accident and he's off work for an extended period. And the pharmacy manager decides to distribute his usual tasks, and the pharmacy manager herself takes over the waste destruction and disposal process and is surprised to find very, very little product actually to be wasted. So the manager investigates further and finds that for years, Carl has been pilfering waste and ADC opioid stock. So how would your facility approach this incident? Would you simply say that Carl's a bad person and we could have done nothing to prevent this? Or are you thinking a bit deeper, taking more of a systems-based approach to this? Honestly, ideally, you would already have thought about some of these vulnerabilities in your medication process rather than just reacting to individual incidents as they come to your attention. You already would ideally have plans and procedures in place to bring in the appropriate people to report, to start other sort of investigations and other audits and other. So to help understand the issue from a systematic lens, the literature identifies two main dynamics of diversion. One is failing to maintain the physical security of controlled substances. And some of these examples include things like keeping doors open, not locking out, leaving unintended product available. And the second main dynamic is falsification of clinical or inventory documentation. And these are things like intentionally misdocumenting how much you ordered, how much you administered or wasted, but also clinically, such as artificially increasing patients' pain scores. And certainly things like falsifying signatures or miscounting drug inventory would also fall into that. Now, out of these two main dynamics, oops, I skipped one slide. So out of these two main dynamics emerge five main principles of diversion control. One is certainly diversion control, so physical control, so maximize the physical security, take out only what you need, make sure it's locked when it's not needed, and use it as quickly as you possibly can. And also to minimize the access to it. So limit the number of people who can have access and limit the amount of time it's unsupervised. The three remaining principles refer to data. So make sure your data is accurate and complete. Ensure that it is you are capturing everything you should capture. Things like all the relevant attributes you want to know about this. Make sure they reflect the appropriate quantities of controlled substances involved, and make sure they're verified by a second source if possible. Ensure that the data is consistent. Make sure it's standardized from clinical area to clinical area, and this helps to make outline use stand out a bit more and makes it easier to appreciate. And certainly data monitoring needs to be done. There's no point in collecting any of this data unless someone has the authority and accountability to review it and the tools that they need to review and understand the normal trajectory and life cycle of opioids in your facility. So to sum up diversion thus far, hospitals don't or have not yet broadly implemented safeguards needed to detect or understand how diversion occurs. And we kind of know this because most of the controlled drug loss reports to Health Canada, or maybe not most, but a great proportion of them are actually unexplained. And this demonstrates a lack of traceability needed to fully understand what happened. Certainly the hospital medication use process has multiple vulnerabilities that have been exploited for diversion. And hospitals require guidance to assess their drug processes against known vulnerabilities and identify safeguards. And it's really for all these reasons that we created the Pan-Canadian Diversion Risk Assessment Tool. And I certainly want to acknowledge that early research on this topic was supported by an unrestricted grant from BD Canada. And we did partner with CSHP Ontario branch to help create an Ontario tool that we scaled up. And we do have funding from CIHR to take this tool nationally and to analyze it and learn what we can learn about the landscape of acute care diversion mitigation in Canada. The risk assessment tool is designed to help your hospital identify diversions in the medication use process. It's available for free in English and in French, and all the information, all the quick start guide, the glossary, the user guides, this is available both in English and French. And I really want to emphasize that signing up for the account does give you certainly access to the electronic submission tool, but there's some really good introductory material. There's the reference guide, which does help to point the way to strategies that you can implement after you've used the tool and identify some of the vulnerabilities. It's really not only a tool for assessment, but a tool for learning and improvement. And the assessment categories are organized into key elements, and the figure explains how they're organized. Key elements 1 and 2 refer to hospital-wide safeguards that apply no matter where you are in the hospital, and certainly these are administrative and auditing ones. And the remaining tabs refer to specific stages of medication use as they enter into the hospital, as they're being prepared and compounded and transported to care units, and finally being used and wasted. And here's an example is sort of what it looks like when we started on key element 1. There's a scoring guide, and you'll score yourself on each item, sort of explaining whether you rarely, sometimes, often, or always adhere to these practices. And I think as I bring this up, it's important to know that we're not expecting any hospital to get a perfect score. Some of these are really hard to do, and some are actually aspirational. And I think that when we do an analysis of all these submissions, there'll be some items here that no Canadian hospitals are doing. However, I think they do point the way to future work that we can, start to think about and start to implement as we improve this. And sort of returning to our case study. The vulnerabilities in this case have been exploited for years in the case of Carl, and can happen in any institution, really. And when you have one go-to person like Carl, who can do everything, there's some degree of efficiency in that, and even maybe some degree of security because they know everything and they know everybody and where things are. However, having one person do this creates a huge vulnerability. The same person who controls the physical medications and the documentation dramatically reduces oversight of controlled substances. So the Pan-Canadian Diversion Risk Assessment Tool has several risk assessment items that deal with this particular vulnerability, such as item 29, separate purchasing and receiving roles. And I think most hospitals do this already. But again, we emphasize independent verification of different steps in the process, and then reconciliation of these different steps to highlight discrepancies. And item 25 here emphasizes when you're doing inventory counts, again, make sure there are 2 people to verify this, always ensuring independent, accurate, and complete documentation. And as highlighted in this case, it's important to look at your waste processes. Sometimes we don't pay enough attention to it. It is a source of controlled substance and should be treated as such. Making it irretrievable and unusable can help prevent diversion, and making sure that the waste receptacles are secured and it's removed from premises can help reduce the risks associated with this. We also need systematic approaches to controlled substance oversight and monitoring. And hospitals, again, collect information and can collect the data, but often lack the accountability and responsibility infrastructure to ensure that this information is reviewed and acted upon. And so I hope that the last few minutes, somewhat interrupted, have demonstrated to you how the Pan-Canadian Diversion Risk Assessment Tool can help your organization identify risks and implement approaches to mitigate these hazards. We really encourage you as an acute care facility to sign up for this. It's free, it's available in French and English, and please submit. Once you submit, you'll be able to compare your facility to other similar but anonymous Canadian facilities. And importantly, we're going to take that aggregate data, the de-identified aggregate data, and really get a sense of what's going on in controlled substance diversion mitigation in Canadian hospitals. And we're excited about this because I don't think it's ever been done on a national scale anywhere yet. So you and your organization will really be contributing to something important. And I'll turn it over to Ambika.
Thank you, Mike. And if the other presenters are amenable, maybe we can kind of jump into some of the questions. that we've been getting. So thank you to everyone who's participating in the chat and the Q&A. So we'll start with Jude for the SGLT2 inhibitor. So when SGLT2 is put on hold by default, do we convert the patient into insulin?
So it doesn't happen automatically. What would happen is anytime you're going to hold a medication that's addressing care, we're going to need to look at alternatives. So all the meds are going to be reviewed and some other agent may be used in that case, because obviously you can't just take away the therapy.
Great, thank you so much. And another one that you did type a response. I don't know if you want to elaborate verbally as well. How do you deal with SGLT2 inhibitors that are restarted in ALC patients? So patients awaiting rehab, long-term care, or other supports for discharge.
Yeah, so that one's pretty straightforward. I think in that case, if they're an ALC patient, they're probably fairly medically stable, so there wouldn't be the same concerns that we'd have with the acute ill. But still, it would have to go through a specialist. So what would happen is they would order a consult in the system from the IDMS team, and then if the order was appropriate, they would place it and it would go forward.
Excellent, thank you. And I did have 2 more questions that were sent directly. So you haven't had a chance to type answers yet. Do you have medical directives in place for pharmacists to hold all the sick day medications, the SAD-meds that you listed for acutely ill patients, or just the SGLT2 inhibitors?
We do not have a medical directive for all of the other SAD-meds. It would be something that would happen during clinical review, but the medical directive really came out of the potentially significant patient harm cases with these SGLT2s.
Excellent, thank you. And I just see another question also came in. Are you aware of any differences in the risks of euglycemic DKA between the different SGLT2 inhibitors, or is it a bit more of a class effect?
Definitely class effect in our experience. I see all of them as reason for admit within DKA when I submit reports to Health Canada. I think to draw a further conclusion, we'd have to know how many of those reports would have to go over the denominator of how common are they, because I presume one of them probably gets prescribed more than the others, so that would have to be factored in. So, but in brief, no, I think it's an issue for the whole class, and we don't see a front runner, as it were.
Mm-hmm. Okay, thank you. And just the last question that was sent to us. We sometimes forget to restart held medications or forget to alert patients or caregivers. So how do you ensure that this temporary holding of medications doesn't lead to inadvertent problems after discharge or in the community?
Yeah, great question. It's a great segue into the value of discharge medication reconciliation, isn't it? We do use Epic as our system, and there is a discharge navigator that kind of really guides what was on the home medication list as well as what's in hospital, and then what they're either going to continue or not continue on. So there would be a prompt for the prescriber to reassess that medication. They would see on the list that we held it and that it was a home med. So I think that answers it.
Okay, great. Thank you. Yeah, that's a great system. So for Harneet, the sheer number of diabetic medications marketed under different names and dosing regimens and delivery devices is very confusing, especially now that the indications for these drugs extend beyond diabetes treatment. Is there any advice to help practitioners?
Hi, so I think one thing that's important is becoming familiar with the classes versus each product or each drug. Knowing about what each classes can do, their mechanism of action, can help guide decisions during prescribing. Some classes of anti-hyperglycemic agents, for example, offer more benefits for cardiovascular patients with cardiovascular disease, such as SGLT2 inhibitors. And I think referring to guidelines during prescribing processes could be very helpful, especially if you want to consider patient factors, such as the risk of hypoglycemia in the elderly when using sulfonylureas and insulin. There are a lot of antihyperglycemic agents, like for example, OZEMPIC is something newer and it's used more and more frequently now, and it is getting more complex. Another thing that could help prescribing and in the pharmacy process as well is perhaps having detailed information in the electronic prescribing and dispensing systems so that we can refer to that information in the pharmacy or while prescribing to, I guess, guide those decisions, and also engaging the patient or the caregiver to make sure they're aware of what they're using, what they're taking, and why. Again, I think just having either a reference in the pharmacy or references in the electronic prescribing and dispensing systems themselves can be very helpful.
Great, thank you, Harneet. For Mike, these are two questions in the Q&A box. Are you aware of any similar initiatives, so data analysis, risk assessment, tool development underway specific to community sites that handle controlled substances, so pharmacies or clinics?
Yeah, that's a terrific question. In our cost of opioids loss study in 2020, by far the greatest losses of controlled substances were in community pharmacies. And there are very different reasons, maybe from a hospital. Things like armed robbery tend to occur in community settings, break and enter again more often in community settings. But in our work actually in long-term care also identifies controlled substance as an issue. So both are real important areas of concern. I'm not aware of any ongoing project or ongoing study or anybody else looking at this. I think that's a great avenue for us to pursue once we sort of advance our work related to acute care. I'm not aware to answer your question directly, but I think it's a very important part of the overall picture in preventing diversion and preventing sort of loss of substances.
Thanks, Mike. And last question for today, is the tool applicable to small rural hospitals or more so larger hospitals?
I think we purposely made the tool applicable to all acute care settings. We try to make it technology agnostic. So certainly there are questions related to automated dispensing cabinets in there. And we know that there's a wide variety of levels of implementation of automated dispensing cabinets in hospitals. However, a lot of the principles sort of relate to collecting and looking at data, for instance, and it doesn't matter if you use technology to do that. It might be easier if you use technology to do that, but if you have paper versions, that is certainly certainly acceptable way to collect data, as long as you collect it consistently, accurately, and you have people looking at it. Similarly, some people have large centralized pharmacies, some bigger acute care hospitals, some have smaller pharmacies or rely on external pharmacy consultants to provide care. I think it is applicable. I encourage you to do the tool, and if you find things that aren't applicable or that are sort of, if you have questions about it, please get back to us. We'd love to have a discussion about that.
Great, thanks, Mike. So I'll turn it back over to you just to wrap up the webinar.
Thank you very much for a great session. Again, apologies for the interruption in between, but sometimes in live broadcasts, this does happen, and I appreciate your patience. Love the question and answer session, some very excellent questions. And I want to thank all our presenters for the terrific learning that they shared today. And want to thank you, the audience, for spending time with us today. We learn from you, and I hope that you take away something from us that you can use. And we welcome you to our very special webinar in September 2023. We have not yet set a date, but is in conjunction with World Patient Safety Day. And certainly the theme for this year is engaging patients for patient safety, and we'll have a terrific lineup again for you. So thanks for spending some time with us. Please fill out the poll and enjoy the rest of your day.